Good evening, everybody. My name is Suzan Thompson and I'm currently a matron at Epsom General Hospital. I joined the Trust in 1993 and worked for 17 years in the emergency department at St Helier and then latterly at Epsom General Hospital. About 18 months ago, I moved from the emergency department back into the general wards, the general medical wards. So what I'm going to talk about this evening is a brief overview of the role of the matron. Now, originally, and I know the way it was publicised, was a day in the life of the matron. But as my colleagues will tell you, the diary that starts off during the day frequently gets changed very quickly and very rapidly. So a day in the life of the modern matron, actually there is no normal day in the life of a matron. Briefly touching on the history of the matron, and I'm sure we all have our views, and of course the most romantic view is of Hattie Jakes, and I sort of lose count of the number of times a week that I get people saying, "Oh, matron," to me, be it staff, relatives or patients as well. But the image was of a bit of a battle axe. Now, whether I'm still a battle axe or not, I don't really want to know. However, the role of the matron as we always remember it, that romantic view of it, actually ceased in about 1966, following the publication of the Salmon Report. Many resisted the abolition of the matron role, but this report sort of assured doubters that the profile of the nursing profession would be raised and they would have a greater say in management. However, what became apparent was this central figure in charge of the standards, and the lack of that one actually had an impact on the quality of care. In 2001, the NHS plan came out with implementing the modern matrons. Thankfully, 10 years hence, we've lost the term modern because it actually irritates me, I have to say. However, the important aspects of this was the role of the matron was to focus on standards of patient care or patient safety, to be visible to staff, patients and relatives. That would be the patient experience, reflecting back to our core values, and also leadership as well. And this is where we're at now. We wear turquoise uniform. There are 24 matrons now in the Trust, and we mainly, rather than looking after the hospital, we now look after a group of wards or a department. I look after 5 of the medical wards on this site, and that's approximately 122 beds. And the central focus of our work is quality care. It's improvement and maintenance of standards of the care that our patients receive. Quality is at the heart of everything we do, and we liaise closely with all our professional colleagues across the Trust to ensure high quality of care. So, firstly, about patient experience, patient safety. We go back to Florence Nightingale from our roots, and it is as evident now as it was then that it seems a strange principle, but the very first requirement in a hospital is that it should do the sick no harm. First and foremost, to ensure the standards of care, we need to ensure that we have the correct staff on the ward, and the correct numbers that have been correctly trained, have the skills and the resources that they require to provide good quality care. We've reviewed recruitment, and we now very much focus on whether the staff that we want to employ can demonstrate that they can look after the patients to the standards that we expect. We're involved in the establishment reviews, and we've also used the tools called the Safer Nursing Care Tool to actually direct us towards the dependency of patients and acuity, and whether we've got the correct nursing numbers to actually provide standards of care. We also receive twice daily reports. Now, I remember this from when I was a staff nurse back in 1980 something on the ward, where we would have to deliver twice daily reports to the senior nurse telling them about the acuity of the patients on the wards, those patients that were causing us concern. And we've reverted back to that now. So 6 o'clock in the morning and 6 o'clock in the evening, we will receive reports. These go to us and to the clinical site managers, so that if there are patients who give us concern, we can go back and review them, support the nursing staff in actually delivering care, and write plans of care as well. Equally, when we're alerted to increased dependency of patients on the ward or a patient, then we will go to the ward, we will risk assess those patients, and we will put in plans of care and additional resources if it's required. SBAR is something that we introduced earlier this year with the help of the practice educators and the resus department as well. And it's a very simple communication tool. For us that have been in healthcare, we know that when we need to get a message across, your mouth goes dry, slightly like mine has now, and you forget exactly what you want to say and how you want to say it. So this gives them a tool of giving the information to their medical colleagues or even to their nursing colleagues, and they can format it and they can say what they want as a response as well. I want you to visit the ward and review this patient, please. The next factor in providing patient care and patient safety is, of course, the environment. And we need to ensure that the environment is clean, safe and conducive for patient care. And we work with our colleagues in infection control, thank you very much, and Sodexo. If the environment is poor, then we tell them it's poor and we put in plans to make it better and we review it as well. We also assist with the infection control audits. We have those weekly walk rounds. We also have an annual infection control audit as well, and we write action plans for the wards so that they can improve. In addition to the cleaning and all of those bits that we do, we're also alerted to patients who may pose a cross-infection risk by our colleagues in infection control, and we work with them to ensure that they are isolated and receive the care they need so that they don't pose a cross-infection risk to other patients on the ward. And nutrition as well. And it would be foolish of me to stand here to say that I've ignored all the national press about food being taken away before it's been eaten, fluids being out of reach, or patients being admitted or discharged who are malnourished. We've worked with our colleagues in Aramark, the dietitians, the speech and language therapists, and the tissue viability nurse as well, to ensure firstly that all patients within 24 hours are assessed for malnutrition. Based on that assessment, a plan will be put in and special diets will be ordered. We then need to ensure that those are being adhered to, but also that it's having the desired effect as well. We monitor meal times, we assist with feeding as well when we need. The red tray system is probably fairly well embedded in most NHS hospitals, but it alerts the staff and everyone else to those patients who may need help or additional assistance in actually eating as well. And it also alerts our staff in catering that actually not to take the tray away until they've checked with the nursing staff. The Protected Mealtime Initiative has been instrumental in making sure that our patients are not disturbed or interrupted by medical staff, physiotherapists. They're not taken away during meal times. They have a period of disturbance-free time so they can eat their meals. In the last 6 months, we've also introduced red jugs, red mugs as well, and those are for patients whose hydration status may be giving us cause for concern. For those patients, we encourage the nursing staff to give them hourly fluids and make sure that it's being monitored as well. We know if we put some of these things in, and these are but a few of the initiatives that we put in, that actually our patients will be safer. And as such, that improves the patient experience as well. The quality of care includes the quality of caring, and for us this means how personal the care is. whether our patients are treated correctly, with dignity, respecting their privacy and wishes, and also working with their relatives as well. This can often be achieved by analysing and understanding patient relative satisfaction and their own experiences. And when we get it wrong, making sure that corrective actions are implemented so it doesn't happen again. We're there to listen to patients and their relatives and other professional concerns, either through informal, formal meetings, written or verbal communication from the PALS or complaints department, or even just being alerted by nurses on the ward. The meetings we go to are sometimes incredibly difficult to sit there and listen to some of the standards of care that have been delivered. However, it is essential that we gain an insight into the standard of care that we give, and offers us the chance to give honest responses and also put in plans as to how we can improve. We often on our rounds meet patients and relatives during our weekly audits, and generally the feedback is good. When it's not, we take action there and then. We have a patient experience tracker as well on the wards, and they give us ready results of how the ward is performing in respect to things such as communication, privacy and dignity, and environment. We just need to encourage our staff to do a few more of them. And lastly, leadership. Eleanor Roosevelt said, "A good leader inspires people to have confidence in their leader, but a great leader inspires people to have confidence in themselves." We aspire to give the nurses on the ward, through the correct training, professional development, nurturing, information and resources, the confidence to make individual, accountable decisions about patients within their care. We offer support and guidance when required in planning care, and when needed, we direct them to experts to assist in the provision of care. Apart from our daily visits on the ward, we also do nursing ward rounds as well, very much like the model of the consultant ward round. We assist the ward sisters and charge nurse to manage their areas. We support and guide when needed in budgetary responsibility, sickness and human resource management, and we try to only intervene when absolutely necessary. We've found by allowing them to take responsibility for their wards, there's now becomes a pride in their area, and they want to achieve, they want to be able to provide good standards of care. Teaching, of course, I've already said, on the ward rounds and things like that, we teach. The matrons participate in this, whether in small groups, one-to-one on the ward, or in more larger formal settings. And this allows us to share information, knowledge and experience with less experienced staff. However, we also learn from them as well. We currently teach on major incidents, death and bereavement, Maria on safeguarding adults, and we also teach on care of the deteriorating patient. We provide reference materials, safety alerts, information, memos and audit results are shared with the wards, and they're all stored in the matrons folder, which is turquoise. And it ensures that all the information is there for them to be able to access, rather than being strewn around wards or pinned haphazardly up on notice board. We've recently initiated a nursing newsletter as well, and this provides every member of nursing staff with information about new initiatives, maybe things they need to focus on as well, training dates and things that are happening in the trust. How do we know we're getting there? Audit, I'm afraid. An audit is not a new thing. This is Florence Nightingale's audit from the Crimea War, so we're just looking back at our roots again. These audits allow us to analyse, provide our patients and the Trust Board and our senior nursing colleagues with information about the quality of care which is provided within our clinical setting. For us, the most important initiative in the last 6 months has been the nursing metrics, which we introduced probably in April. There are a series of 75 quality indicators that we score the wards on weekly. So on this site we undertake 50 audits on separate patients. The results are then fed back to our Director of Nursing, but they're also fed back to the ward. So they can benchmark themselves against other units, but they can also see where they need to improve as well. So, what have we got planned next? For the patient, we want to ensure that their discharge is safe. So we're doing a project about safe discharge. We want to reduce falls within our ward. We also want to ensure that our patients receive proper pressure area care management. We want to ensure that our patients are safe as well and using the safeguarding policy correctly. We've recently reverted back to manual observations away from the electronic one, because actually a manual pulse is going to tell you an awful lot more than reading it on an electric machine. And fluid balance as well. At the ward level, we want to introduce the Safely Nursing Care tool. We also want to look at the Productive Ward as well, which is a national initiative about releasing time to care. We also want to focus on other national quality initiatives and actually get the wards involved in those as well. At a hospital level, we're involved in the Length of Stay project or the Patient Pathway project. We also want to look at how we can implement the National Dementia Strategy as well. We're hoping that if we can get the right care to the right patient at the right time, then actually we will reduce our length of stay, we will reduce thus the expense as well of getting it wrong.